Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this next video, Professor Miguel Angel Reina from the University CEU St. Pablo School of Medicine in Madrid, Spain, is going to be discussing with us the microanatomy of the peroneural sheath and the relevance for sciatic nerve blockade. If you like any of our videos, do remember to share and like them with your friends. Don't forget to subscribe so that you can get regular notifications of any future upload.
Okay, there are now some problem with the camera from my face, but not by the my presentation. Okay, what are the different structures within the sciatic nerve and also all nerves? You can see a myelinated axon with its Schwann cells. An unmyelinated axon. Here, 10 unmyelinated axons surrounded by plasmatic membrane of Schwann cell. Always, we found package of unmyelinated axon, never unmyelinated axon alone. Here you can see the covering of nerve, endoneurium, perineurium, and epineurium. Sometimes the terminology is a problem. I will consider epineurium only the most external covering of nerve, and fat among fascicle as interfascicular tissue. In this picture, you can observe under transmission electron microscopy a myelinated axon surrounded by collagen fibers. These dots are the cross-section of collagen fibers. This is endoneurium, a permeable structure for local anesthetic. Now, the same sample studied under scanning electron microscopy. Endoneurium form tunnel for each axon. These tunnels avoid electrical field interference. Endoneurium is compact, is not soft. Perineurium is the edge of fascicles. The arrows show the perineurium formed by 8 to 14 concentric layers. Perineurium is formed by cells, perineurial cells. Perineurium is not distensible. Perineurium is the most important structure within the nerve because it governs the passage of molecules deposited outer the nerve toward the target, the axons. This is semi-permeable membrane. The onset time of anesthetic block depends on this barrier. It will be different in different nerves. This barrier is formed by specialized plasmatic shantion as texantion and desmosomes, allowing plasmatic membrane tightly joined together between them. There are not intercellular spaces. A transcellular passage is only possible in the diffusion process. The pinocytosis vesicle process through the cell is another choice. Interfascicular tissue among fascicle is mainly fat, adipositis. It is soft, elastic, distensible, an excellent lipophilic reservoir. This tissue is found among the fascicles. Big and small vessels were within this tissue. Epineurium is the external cover of nerve formed by interlacing collagen fiber. It is permeable structure for local anesthetic. Here in blue, the epineurium. We found recently a cover outer and close to perineurium. This structure is like epineurium but surrounding each fascicle. Therefore, the perineurium is not in direct contact with adipositis. Adipositis are in contact with this new cover. This is a second protective cover in each fascicle. This new cover is permeable for local anesthetic. The barrier is only the perineurium. You can see perineurium in blue, and like epineurium, close outer perineurium. This cover is formed by collagen fiber like epineurium. In this diagram painted by Mary Brisson, you can analyze epineurium of sciatic nerve, epineurium of tibial nerve, and common peroneal nerve, and like epineurium surrounded each fascicle outer perineurium, including interfascicular connection between fascicles. We can see a sciatic nerve block under ultrasound. The needle tip is seen outer the nerve. This is the common peroneal nerve, and this is the tibial nerve, or is the sciatic nerve. After injecting, a donus sign was found surrounding the sciatic nerve at the tibial nerve border. Here, it was found a donus sign, a partial donus in A surrounded sciatic nerve at common peroneal border, and another two partial concentrically donus surrounded at the tibial in B and C. What's more, we found a donus seen as a partially concentrically donus surrounded sciatic nerve in A, B, and C. What will be the donus shapes image in our patients? There are a lot of possible choice. Yes, because sciatic nerve has a lot of concentrically fat compartment surrounded around of it one. Each one of these fat compartments is limited by collagen membranes like epineurium of sciatic nerve, the circumneurons. The needle tip could be placed in this one or another fat compartment, and different donut shape may be developed. The same local anesthetic volume could be entrenched in one or another fat compartment with different spreading and logically with different outcomes. The innermost fat compartment, innermost donus, will perform a base block, lesser onset time, and a longer duration. And we perform a block injection within an outermost fat compartment. A poor block will be reached with a longer onset time and shorter duration as a result. Could it be an intraneural injection within sciatic nerve? Macroscopically, sciatic nerve is a nerve, but microscopically, sciatic nerve does not exist at that level. They actually are two different nerves. Each nerve has its own protective epineurium, but basically it is a terminological problem. In this case, local anesthetic volume was injected in the rear innermost fat compartment of the tibial nerve and common peroneal nerve. Conceptually, this one is not an intraneural injection. In this picture, we see several concentrical circumneurions, also named paraneurion or circumneurions. The origin of the circumneurions are the adventitia of the vessel. Please you follow the arrows. An epimysium of muscle is another source of paraneurion. Please follow the yellow arrows. This is the epimysium. This translucent membrane is epimysium of muscle. This aspect is similar to circumneural membranes. All nerves that we would like to perform an anesthetic blow are within fat compartment, immersed within fat. Fat always surrounds the nerves. There are not nerves without fat in close contact. Fat is the essential element for spreading of local anesthetic volume to occur, and the border of fat compartment is the circumneurum that limits the pathway where the local anesthetic volume spreads. The pathway where the anesthetic solution volume may spread appear among the adipocytes simulated in this marker in red. Adipocytes are not broken or crushed. Adipocytes are detached from the protein matrix that fixes adipocyte among them. The adipocyte tissue is soft and distensible. Here, details of adipocytes are marked at more magnification. This is the real pathway of local anesthetic volume when we perform an anesthetic block, injecting near the nerve, or also in a fascial block. Fat is the most important element for spreading of a solution. All nerves and plexus considered for us in the regional anesthesia techniques are surrounded by fat. Fat is the key word. Macroscopically, sciatic nerve is a nerve, but microscopically are two nerves from its origin, tibial nerve and common peroneal nerves. Each one had most conglomerate fascicle at popliteal region than gluteal region. The fascicle number is greater at gluteal region than popliteal region, but the fascicular area is lesser than other one. As a sciatic nerve is formed by two nerves, the tissue outer this nerve is actually like first an innermost fat compartment limited by the innermost circumneurum. For this reason, it's possible to find septae within sciatic nerve. These septae are extended membrane with origin in this circumneural membrane and vessel within sciatic nerve between tibial and common peroneal nerves. All these new concepts were obtained from microscopic view. This circumneurum will be the classic epineurium of sciatic nerve from a macroscopic view. You can check the different septae within sciatic nerve in light green and its epineurium in dark green. Using another terminology, the dark green line will be the innermost circumneurum of tibial and common peroneal nerve, but both descriptions are right. In a standard anesthetic block, the local anesthetic volume is injected outer the nerve, outer the epineurium of sciatic nerve. The volume is spread in all directions. The approach within sciatic nerve, but outer tibial and common peroneal nerve at popliteal region could not be an intraneural injection from a microscopic view, although it might look like an intraneural injection from a macroscopic view. The size and shapes of fascicle and the needle's orifice until now have not been considered, and these aspects are certainly relevant when we are considering an intraneural injection. Here, intraneural but extrafascicular injection appear in blue. Local anesthetic distribute exclusively around outer fascicles. This is a simulated extrafascicular injection. The vessel may be broken, originating an extrafascicular intraneural hematoma, fibrosis, and in the future probably develops dysesthesias. This type of lesion is unpredictable. The possibility of intravascular injection is real, but remember, fascicle tissue has little distensible properties. Endoneurium is more resistant and harder than fat located in extravascular tissue. Here you can see an intraneural intravascular injection. You see fascicle and vessel, but it is important you check the diameters of needles and diameters of fascicles. A catheter may be unintentionally inserted within sciatic nerve, but where? Actually, in this picture, this catheter was not intraneurally inserted. Truly, from microscopic view, this catheter was placed within the innermost fat compartment located between tibial nerve and common peroneal nerve, but not intraneurally. The concept of an intraneural injector remained unchallenged until now. There are two possible ways on the intraneural injection: intravascular or extravascular spreading may occur. Such concept has been supported by experimental studies after injecting particulate marker, known as Indian ink. These concepts were generally accepted. However, our findings were significantly different when another marker was used for us. This is the traditional marker, Indian ink, used in the most studies. But what was the problem after to use this marker? It is not possible to identify singular particles of Indian ink, which are always seen as black spots formed by particles clamping together, possibly by electrostatic forces. Here, all joined particles at high magnification, such as 30,000 times. We developed a new marker and performed deliberate intraneural injection to evaluate the possibly intravascular and or extravascular injection. This marker was human blue heparinized with high doses heparin diluted around 15% hematocrit. Our surprise in human sample was high in our lab when we found that it was very difficult to achieve a spreading of a solution inside the fascicle after a deliberate intraneural injection, checking with swelling under ultrasound. We performed the intraneural injection in poor condition. 20 milliliters injected within sciatic nerve, and logically high pressure were reached. Most of the blood injected was found between fascicles, but almost always outside the fascicles. The marker had a spreading inside and outside sciatic nerve, within tibial nerve, but always outer fascicles. The fascicles were always clean. At more magnification, you can observe all fascicle clean, free marker. As you check, marker is outer the fascicle and nothing inside fascicles. After performing a deliberate intraneural injection, there was only marker outside fascicle and most fascicles were marker-free. You can see how the injected intraneural marker was retained by Epineurium inside the nerve and how marker does not leak outside the nerve. The same image at more magnification, you can see Epineurium and retained marker. Here we see how the marker spread between fascicles but does not pass across perineurium. After a deliberated intraneural injection, epimesion also retains the marker, avoiding the spreading through muscle. Here, there are not adiposities among fascicles, and here, there was not intraneural spreading of solution. In this case, the spreading occurs only outside the nerve. All fascicles are clean and agglutinated. Fat is the key for intraneural spreading, and it is important to remember that not all nerves are seen, not all nerves, trunk, of course, have adiposite among fascicles. An important finding was to observe the marker between the layers of perineurium, which produce widening of perineurium that from an ultrasound view can be misinterpreted as fascicle swelling. But inside fascicle were clean. There was no marker between axons. There are also perineurium septae, and marker is spreading through them. It can be misinterpreted as intrafascicular injection, but axons are clean on the picture. The increasing diameter of this fascicle is caused by intraperineurium widening, but not by intrafascicular spreading. The use of Indian ink would not allow the examiner to appreciate such details, and this finding could be misinterpreted as intrafascicular spreading. At more magnification, you can see the same, but in details. The marker spread through the perineurium layers. Tibial nerve inside sciatic nerve may have 35-40 fascicles, but in general, only one fascicle of them may be affected. Yellow arrow, only this fascicle, not the rest. At more magnification, after using a new marker, you will see that this is a pseudo intrafascicular spreading. Actually, it is not an intrafascicular injection. Instead, there is intraperineurium spreading through the perineurium septae. This is the spreading through the perineurium layer. This is the septum of perineurium and spreading through this septum. The same image at more magnification, showing details of spreading through the perineurium layers. At more magnification, a dilation at the end of perineurium septum thus can be misinterpreted with an intrafascicular injection. Overall, when another researchers had used Indian ink as marker, overall in the past. Now the question is, why is it so difficult to produce an intrafascicular spreading? Because the fascicular tissue was underestimatedly taken for soft tissue, and instead the axon and endoneurium are rigid, hard, and resistant tissue which prevent the passage of the substances across fascicles. The property of the endoneurium hold the key to understand such new concepts. Vulnerability of the nerve was another topic. This mathematical analysis allows to better understand the different risks of nerves subjected to the different anesthetic techniques. After superimposing the microscopic full cross-section of nerve and the needle orifice image, we scan vertically and horizontally all possibilities to identify the needle orifice at different percentage of occupancy with fascicular tissue. We developed a software to acquire this data, advancing the imaging of the needle orifice over the cross-section of full nerves, allowed us to make accurate calculation of the risk of making an intrafascicular injection. Now, this is the software, and barrier in vertically and horizontally region of the same image. And now this is the zero, zero full occupancy. But now 2, 8, 16. Okay. We consider that this risk could be high, over 80% occupancy of the needle orifice with fascicular tissue, blue places within the nerve. To aid the interpretation of this diagram with assigned color to each percentage value. And dark blue color is a full occupation and a high risk. There is a color bar with the correlation of occupancy percentage of each image. This allows to quickly identify the most sensitive places to the risk of injury by intravascular injection in a nerve. The blue mark the highest risk of intravascular injection within the nerve. This risk may be modified after using different needle diameters or bevel angles. Approach in different angle is another choice affecting the risk of intravascular injection. You can check the picture after using 15° or 30° on the needle bevel, as well as an approach at 45 or 90°. This study was performed over sciatic nerve at subgluteal region, and the blue dart is varied in different conditions. And the same method were also applied to sciatic nerve at popliteal region. The blue color marked the risk places in different conditions. So, unfortunately, we have reached the end, and it was a pleasure for me to share with you all our experience in our lab, and I hope that our result may be useful for you in the future and in the hospital. If you want, you can contact me through my email address. Thank you so much. Muchas gracias from Madrid.